All right. Thank you for coming back. So our final, but my most exciting, that I'm excited about, speaker for this afternoon is Dr. Shantel Hebert-Magee. I got to hear you talk actually at this past fall state sickle cell symposium and got very excited to hear about Medicaid's encouragement of and their advocacy for sickle cell patients and then their coverage of high cost gene therapy for that condition. So immediately thought, as we're covering advocacy of all types of care, talking about a lot of access and cost of care, come talk about some of access for cancer patients to high cost care. So Dr. Hebert-Magee is our Chief Medical Officer of State Louisiana Medicaid, and thank you so much for accepting our invitation to be here.
Well, good afternoon, and thank you for having me. Don't be too excited. I don't know if anything I'm going to say is going to be revelatory, but I would hope to unpack what we deal with in Medicaid. I ideally would like to give a general overview and speak to our achievements as well as some of the barriers that we still have that are inherent to Medicaid as a program, but also some of the challenges we have within Louisiana Medicaid when it comes to cancer therapeutics. So before we discuss Louisiana, right, I always get a barrage of questions, emails, phone calls, people telling me that commercial insurer covers this, or Medicare covers this, or Medicaid in another state covers this. And so I think it's important to compare apples to apples, or crawfish to crawfish, not to lobster. And this happens so often. So just to give just allow for everyone to have the bird eye view. Coverage varies by state, all right? So we know that there are no two Medicaid programs alike. There are no two Epic programs alike, if you're one hospital system versus the other. And so eligibility criteria also varies by state. It's not just a comparison between expansion versus non-expansion, but there are a litany of different types of Medicaid programs, and the eligibility based upon the federal poverty level may vary between each type. But what all programs have in common, unfortunately, universally, is that we have problems with trying to get providers because we have lower reimbursement rates, right? But it's not just that. It's also where our members are domiciled. People like to be in glitzy, glamorous places. They don't want to be on reservations. They don't want to be in small communities, particularly if they have young kids. We are a global community now, and so people want to feel that they are close to resources. And so even for our providers, it's a struggle to try to get them sometimes in some of the more remote areas of our state. So if I was to ask you, which Medicaid programs have comprehensive cancer coverage, including access to novel therapies and medication, which states would you think of? Come on, yell out a few. Massachusetts, okay. What else did I hear? New York, California. Okay. Man, you all just hit the jackpot. So, these are the states that have the most comprehensive cancer coverage. And it's not by coincidence, right? It's not serendipity. It's not happenstance. The reality is that California and New York have some of the highest GDPs in the country, right? California can function as a small country based on its economic output. And then we look at states like Massachusetts and Washington. Not only do they have relatively high GDPs, they also have half of the percentage that we have in Louisiana when it comes to coverage. Louisiana covers roughly 40% of the population through Medicaid, some type of Medicaid. And you see in Massachusetts and Washington State that it's half that population. But I'm going to speak to this a little bit later, is that it's also the population that we're covering, right? It's like, would you ever have to give, or how many mammograms would you give to college-age basketball men? Probably not very many. And so therefore, that would be a good risk pool to ensure if you had to give coverage for that. Unfortunately, in Louisiana, we have individuals that have significant chronic comorbidities and diseases. We have low educational attainment. We have widespread poverty, unemployment. All these are precursors that can have negative downstream effects when it comes to healthcare access and outcomes that we need to deal with. So we can't just think of funding and facilities in silos, but think about the totality of what affects a person's care. So if I was to compare ourselves to Big Texas, right? They got this song, "Where Your Fans At." I don't know how to do the dance, but if anybody's seen the video, it makes me think of Texas and rodeo, and we talk about Big Texas. And Texas has the highest GDP, or second highest GDP, right behind California. So you would think about their Medicaid expenditures. And if you were to compare it to Louisiana, it still covers more than a third of their state general funds. So why is this the case? Texas has a more restrictive traditional coverage, right? You can't just be poor. You have to be poor and pregnant, poor and a child, or either poor and disabled. So for all these people that develop cancer or any type of condition, what happens? They go to the hospital. And so you have the dish. You have the uncompensated care costs. So either you pay up front or you pay behind. The good thing about Louisiana is because we did expand, the one thing that we do offer, despite having, some of the undesirable social determinants of health, is that we have more coverage than Louisiana when it comes to cancer care, because we do offer prevention, screening, and treatment. It may not be as broad as we ideally would like, but we are better than Texas. Even though they have MD Anderson, most people there who are underinsured or uninsured don't have access to those facilities. So sometimes, people say, "Oh, I want to take my coverage. I want to go to Texas. I want to go to Texas." And I'm not talking about people who are proximate and that's closer to them, but people who feel like they will have more access. And that may not necessarily be true. So what are we doing well in Louisiana Medicaid? Well, I can speak about what I'm doing well, right? So this is my report card. So one thing that I do take to heart is to make sure that children have coverage. So it's not uncommon for me to get emails late at night on the weekends. And so this is an example. It was right before a holiday. And the person said, "Hey, I have a friend who has a child who was just immediately diagnosed with osteosarcoma. They were headed to go on vacation, and they have already exhausted their resources." So when we typically think of Medicaid, right, we're thinking of those who are destitute, uninsured, underinsured, but also it becomes the third-party liability for many who have, exhausted their treatment plan. So if you've been having a child tested for multiple months and so forth, and finally you get a diagnosis, and you can't cover it, your insurance say you've reached that upper limit, we call it the stop loss, and it's not going to be covered anymore, then the person comes over to Medicaid. And so I do my best to try to get children as well as adults enrolled as quickly as possible. For our kids, they have EPSDT. So therefore, we have to cover anything that is medically necessary. So there shouldn't be any issue in trying to get them treated for oncological conditions, and so that's something that my phone and email I always respond to. This is another thing. So I think Dr. Rini had mentioned the BCC program. So she's right. BCC is something that happens. It's also a federal program that is operationalized at the state level. The challenge is that all these BCC programs work independently. So if you qualify for BCC in Massachusetts, you may not qualify for it in Louisiana, right? Because it goes off of your income. So we talk about garden variety Medicaid and what is the coverage. Typically, it's 135% of the federal poverty level, meaning that a person can't make more than $1,800 a month. That's not very much. However, for BCC in Louisiana, it's 250% of the federal poverty level, so that's roughly $3,300 a month. And I think that is significant because the reality is that many women are the cornerstone of their family's household. Some of them are the only, the sole provider, breadwinner. Some of them assist, but undoubtedly there are pillars and individuals in the household, whether it's elderly or kids, rely on them. So it's important that we have that provision. So imagine if you're receiving your care and now you say, "I have to go to be closer to my family, so I'm going to move back home to Louisiana." and we tell you that we're going to disrupt your service because you qualified in Alabama, but you don't qualify here? What if you are still receiving chemotherapy? What if you had surgery, but you may need a revision? Imagine that you've completed all that, but you need to have your hormone suppression therapy. And so what happened is that we told the person, well, we can't give you that Medicaid, but what we can give you is Take Charge Plus. Take Charge Plus is for family planning, meaning that we can give you some birth control. How is that going to help someone who needs to have and complete their cancer therapy? The reality is that it doesn't. So gratefully, well, I'm happy that the provider had reached out and say, hey, that's not right. This is not where this person belongs. How can we get this person in? And so I said, hey, this person needs to continue their treatment therapy. We need to override it, recognize that this is a federal program. And as a federal program, there should be an umbrella. So they should be able to transfer. And we were able to close the gap. So that's my report card. But I wish I could do this for every patient. I was just saying earlier that people think that I am the wizard in the Wizard of Oz. And if you get to me, I'm going to make everything come true. But ultimately, I come right back at you and I say, nope, click them heels, sister or brother. And you have to, help me to get these things passed. So what happens, Louisiana, akin to most states, is that we function under managed care. Right? So managed care looks at, risk-based capitation, meaning that they get a certain amount of money for every person that they enroll. Now, you would hope that there isn't too much variability. They know what the risk pool is of having people in Louisiana, our health status. I mean, Dr. Reedy gave us all those somber figures, so they know what they're getting. What they don't know, it was going to come to market. What is going to be FDA approved? What new therapy is going to come out? How much is it going to cost? Who's going to qualify for it? What is going to be the criteria? So in order to try to stave off the cost or try to determine where it goes, is this an outpatient or is it inpatient? If it's outpatient, you can go into PDL. If you go into PDL, then we can have a rebate. If it's inpatient, it goes into per diem. I don't know any per diem that covers $1 million drug or a $500,000 drug. So then that is something that has not been planned for by the actuaries. So therefore, we're not able to cover it. And so I get these phone calls like, hey, you need to make it happen. The reason that we have moved to managed care, akin to most states, is because there was huge fluctuations in the amount of money that had to be appropriated each year when state would try to administer Medicaid. So maybe one year it was I'm gonna make up something, a $7 billion budget, and the following year is $3 billion, and you're like, hey, this is just way too much fluctuation. So how do we have something more stable? That's what managed care does well. However, what we really want them to do is be able to have better healthcare delivery and have reform in delivery models, as well as improve outcomes. And the verdict is still out. We haven't seen it. Most states haven't seen it because there are multiple different factors. Some are inherent to the MCOs because it is a business model, but there are also the variables that we may not be able to control for, and I'll speak to them shortly. But the reason I'm talking about the efficiencies is not just about how they actually administer healthcare through the insurance model. They also are beholden to the state. So LDH may have certain priorities that they have to prioritize. Those are things that we may incentivize to the care plans. How are those LDH priorities determined? They're determined by you. This is where you click your heels. This is when you go to your legislators and say, hey, we have a care gap here. We have patients who are dying. We have patients, their needs are not being met. We have a shortage of providers. We need to increase reimbursement rates. We need to increase this. And because I am internal, so an internal state employee, I cannot advocate. I cannot go to the table and say, this is what I think we should do. My job is to operationalize directives that have been made at the behest of our legislators because they have spoken to constituents and stakeholders such as yourself. So ultimately, the power relies in you. Now, rate setting, I'm not going to get into the nitty-gritty, but pretty much they look at the previous year and they say how much money has been spent in claims. Then they look at the risk pool. And I told you the pool here, it's I don't want to call it a septic tank, but it's not it's not the clearest water. So we have a pool here that's it's hard. So therefore, adverse risk pool. So you have to have people that you know are healthy. For the most part, Medicaid children are the healthiest population. They have the highest enrollment, but they are the healthiest. It's our expansion group. It is our disabled group where we spend the majority of our funds. So how do we keep people healthy? We keep people healthy by practicing preventive medicine. So we try to reward the plans by saying, hey, if you can reduce costs when it comes to ED utilization, acute care, hospitalization, and we will give you money if you can get people to come in and get their screenings for a variety of things, and not just cancer, right? Diabetic retinopathy, come in, let me look at your eye. This is not, anyway, I don't know why I'm doing this. But the point is that, we try to ensure that people are utilizing the tools that they have at their disposal, but it's always a challenge. What are the challenges? Location, right? So all of you smart, erudite people are in this room, and where are you located? You're located in New Orleans, right? You're not in Cato. You're not, you're here. And so the point is that when we talk about our academic centers, our cancer centers, our repositories of knowledge, they're going to be primarily in our urban areas. So they're going to be in Baton Rouge, Shreveport, New Orleans, meaning that anyone else is going to have to travel across the state, including for CAR-T, right? So the one place that's offering right now has to be a FACT accredited facility. And if you are FACT accredited, that means that the person has to come in for conditioning. They got to go through chemo, be in the hospital for 6 weeks, just waiting to be able to get to the point of, procuring cells and send them off to a lab and then having them diffused. And so we know that this is a problem in itself. And then the affordability. And when I talk about affordability, I'm not just talking about, we know that Medicaid patients do not pay a copay. However, there is a copay, right? They have to take time off from work. There's childcare, the burden on the family, the stressors of trying to get there. Yes, we do offer non-emergency medical transport, but you have a 2-hour window from get picked up. You have a 2-hour window from getting dropped back off, plus the time of your visit. That means the entire day is gone. And then how far do you have to travel? I mean, these are all considerations. And when people still have the mindset that, hey, if you cut on me, I'm dead. You get diagnosed with cancer? You let them people cut on you? And these are things that we believed in the 1930s, which made sense. That was prior to antibiotics. And so you open a person up, there was a high propensity to develop infection. Or we did surgery as a last-ditch effort because we didn't have all these novel therapeutics. We didn't have chemo, radiation, immunotherapy. We didn't have gene therapy. And so people still have that mindset because they've had adverse outcomes if they know of things of this nature. So it says better not to know. Or, we're in Louisiana. We have that laissez-faire, live and let live, sirrah attitude. And so it's hard to overcome that when there's a degree of fatalism. And then there's the paperwork. We talk about living in a digital age, but even in the digital age, there's paperwork. We have pre-authorizations. We have people contacting how to get a certain agent, participation in a clinical trial. Medicaid will pay for this. We pay for them to travel, but we don't pay for the agent if the agent is not FDA approved. So it's all these types of considerations that can boggle down the individual who's frustrated trying to figure out they just got this terrible diagnosis. And then for the provider who has, numerous patients, and even though they are concerned about this one, they may not have the bandwidth to be able to deal with this. So, and at the provider level, this is an interesting paper that came out, right? Because people like to point fingers and say, oh, you guys are holding up reimbursement. You're doing this, you're doing that. This is a paper that showed at major cancer centers, academic centers, access to the 4 commonly diagnosed cancers. So colorectal, breast, lung, and skin cancer. And they found that the cancer that people had least access to, so the light green, is melanomas. Because most dermatologists and plastic surgeons, not only do they not take Medicaid, many of them are cash paying practices. And so they would prefer to have commercially insured patients. And so there are things that we have to reevaluate. And I'm not saying for people should work for free. I mean, you should do some missionary work, I mean, in my personal opinion, but I'm not saying every day should be, that you're just working for free. But we have to find some way in which to accommodate these people who may fall on hard times and unfortunately get diagnosed with a malignancy. One good thing that Medicaid has done and the state has done, this is interesting. Louisiana is typically not at the forefront, but on this particular instance, we are on par with California, and that comes to oral oncologic parity. Recognizing that we have people that live in parts of the state where it may be hard for them to engage with a provider routinely, you have to provide oral cancer therapy if they are, in lieu of injections or IV agents, if they are available, recognizing that we have people that do live far away from cancer centers. So we are one of 2 states that have taken and putting that into legislation. So that is a win. But the big deal, the elephant in the room, is drug affordability, right? The reality is that the U.S., the cost of our drugs are way higher than any other part of the world. And even when it comes to drug price inflation, it goes up, it goes up. I mean, we talk about insulin. How does it keep going up when, it should be generic after all these years? But the reality is that we have to deal with the elephant in the room. If we made it more affordable, people would be able to get more access, right? So we talk about macroeconomics. You're able to have more, supplies if the demand is smaller. You have healthier people, fewer people who need to have those therapies. But also, if you make the therapies more affordable, more people are going to be able to have access to that. And so, and that's a challenge that I hope that at the federal level, at some point in time, will be addressed. So, hearing loss. So emerging therapies, I think this is the crux of the conversation here. What's available versus what's accessible? And this is the problem in Medicaid, right? We know about all the novel therapeutics. My phone rings constantly from a vendor who wants to tell me about what new product they have or new application or what Keytruda can be used for now and what can be used for tomorrow. And what should be added to the fee schedule. I mean, I understand. The problem is that my hands are tied because we only have so many funds that are within the coffers. And how do we use that money judiciously and prudently? And so therefore there are restrictions when it comes to Medicaid because, there's only so much. And this does lead to disparities. And I have to be transparent. It's hard to be equitable, recognizing that we have limited funds and on the horizon, we don't know what the future is going to portend, but the reality is that we have to be innovative not only in the products that we make, but also in how do we provide access to those products. The real impact is on the patient, right? And so we know delayed treatment leads to worse outcomes, but also I like the last one under the little carousel with the horse is lower quality of life impacts patients, suffering impacts the family. And I think there's something very poignant about that. And so I always ask providers, is there opportunity to give this person this agent under a clinical trial? Like I said, we may not be able to pay for the agent, but Medicaid can pay for some of the ancillary support in order to allow for that person to be able to travel to a place that's able to give them said care. Also working and partnering with other entities that are able to provide certain services that would be able to make the quality of life for that person important. And we always try to, support case management. Right. So if they can support the, housing and bills and things that are so the person is able to focus on getting healthy or trying to address end of life issues and not have to deal with all of the background noise. What we have done is that we have had value-based care agreements, and this is where we're really trying to get our care plans to focus on prevention. And so they offer $50 for people to go in and get their colonoscopies, things of that nature. But the reality is that, there's still individuals who I mean, I just met a 60-year-old woman who never had a mammogram, colonoscopy, or pap. So, and she was like, "Oh, I don't need to have that. I'm healthy." So, it's hard to convince individuals who have a certain mindset. And so incentives is not the only thing that you have to do. It requires a certain degree of education. There's the risk sharing. So some of the conversations that we have had with pharmaceutical companies recently when it comes to these gene therapies is, if it works, great. If it doesn't work, what do we get reimbursed back to the state? If the person, starts off strong, but then it wanes after a particular period of time, the gene expression changes, is there a certain degree that we will get compensated back to the state? Trying to find a happy medium, so therefore it is not just completely cost prohibitive. And we're hoping that we're able to do that. But then we also believe in gang mentality. I mean, we're not trying to say we're enforcers, but I think there is something that you can do when it comes to collective bargaining, right? So if all the states get together and say, "Hey, Big Pharma, you got to give us a break on this," then we have better opportunity to leverage and hopefully get access to this. So this is something that when it comes to CGT for sickle cell, the federal government did negotiate on behalf of states, and depending on the number of states that participate is going to determine how much we pay for these therapies. So the more states that participate, the cheaper the therapies. I'm hopeful that when it comes to some of the CAR-Ts, diffuse large B-cell lymphoma and all these other implications or that can be applicable to, that we're able to give access, because under the current law, it's in the per diem, but we know that no hospital is able to pay that upfront and wait on the end of the year cost report to get reimbursed. It's not feasible, it's untenable given the number of patients that potentially could qualify for said therapy. It all comes down to a collaborative effort. So patients, tell your story, advocate, go before the legislators and say how it made a difference, how early detection, how having access, how, everyone loves kids. So if kids go up or the parent go on their behalf, it's always our tear jerkers, and that moves the heartstrings. Providers, right? So they need to hear for those who are in the field who say that I'm having challenges. I can't give this particular patient Pluvicto. This could extend this person's life, allow for them to go to a graduation, allow for them to, and so those are the types of things where you have to go and say, what is the application and how, through evidence, that this is going to extend not only the length of life, the quality of life, and how would this make this person's, life better, but also how does it stave off additional cost, right? The whole emphasis on preventive care is that you don't have to deal with the expensive, more complicated, more challenging care tribulations later on if you're able to catch something early and address it. And that's where the advocacy and the policymakers come in. One of the things that we are participating in, I was in talks with ACS, and they came and say, what can we do to try to increase the number of children to get vaccinated for HPV, right? So prevention is key, right, to prevent them from having HPV-related malignancies. And so 2 of our MCOs are currently participating in this model. It's a pilot. It's learning how to advocate. It's learning how to have those health literacy conversations. I had a conversation with Exact Sciences as well as the Florida Medicaid department because they were able to increase their colonoscopy screenings with Cologuard by upwards of 16%. And I said, how did you do it? And the first hurdle that they had to overcome was health literacy. People got the Cologuard in the mail, they got the package insert, and still did not know how to use it. I mean, so many of these products, I don't know who they do the beta testing on or the focus group, but they're not our population. And so I think that, it should come with a king cake and a Mardi Gras bead in it and tell you how to how to turn it or something where the baby is in order to get people to, understand. But it has to be, I think it should be colloquial, local. It has to have a certain degree of cultural competency in understanding who your targeted audience is in order to be able to get them to use it. And they say once they were able to cover that hurdle. It really expedited the number of people that actually got tested. And so my last slide here is the call to action. I wish I could say that we had more money. I think that there were sombering talks earlier about where we're going or where we believe we're headed regarding this administration. But just overall, our healthcare expenditures in this country are just astronomical and out of control. And I always say that America has a very prescriptive pattern, right? Anytime we go to a doctor's office, everyone in here either wants to receive a prescription or a diagnostic test, including myself. I'm like, if I'm taking off from work, that means I'm sick. And darn it, do not tell me go have some aromatherapy and get a good night rest. I want to test. And so that deals with some of the issues when it comes to overutilization of like multi-gene panel tests for RSV, influenza, Ebola, everything is on these panels. And you're like, that is not necessary. But the reality is that people, when they visit a provider, a ED, urgent care, they want to either receive a prescription or a diagnostic test. And so we have to change that mindset. And I think not only changing that mindset and educating people, but actually focusing on prevention and getting people to realize that, hey, the way you live longer is to come in and have these conversations, and it can be a game changer. Streamline processes. It shouldn't be this challenging to get people in. We spend so much money on case management, and we do it at the tail end. Once there's that flag in the system saying that they're a high utilizer, why don't we flag them beforehand? We have AI. AI can screen and look at all the different risk factors. And if you see a person has a high risk factors and they haven't been in to see a clinician, even though they have coverage, right? We have people that are enrolled in Medicaid, but they've never seen a doctor because they still interface with the healthcare system on a needs-only basis. Oh, I need to go in. I have a UTI. I need to go in. And they go to the ED department. So how do we change that? And that's where case management, you can't come in once they already have a malignancy and say, okay, how can we deal with this in palliative care and hospice? It should come in at the very beginning, before then, when you recognize that this person has risk factors and they have not seen a clinician. And then increasing funding. I want money. If any of you have grants and things that you think you can do in partnership with Medicaid, I always write letters of support if they're going to help our population. If you want to do research and use Medicaid data to better be able to inform policy, to be able to bring before our legislators, I support that. I think we have to be innovative and creative in how we move the needle. And final, drug affordability. I mean, that's the elephant in the room. So this is where we are. I don't think it's too abysmal, but there's work to be done. Thank you.
Right, this session is open for questions.
So I have a couple. Sorry. Just about a couple things you touched on. So CAR-T specifically, can you explain a little bit more about what you touched on about the reimbursement issue facing hospitals, like with the end of the year part, and then what, if anything's being done about it?
Sure. So when CAR-T came about, everyone was excited. It can be applicable for a few different types of, blood tumors, diffuse large B-cell, multiple myeloma. I'm sure there's some other indications. And then we looked at the cost of these therapies, just for the, that whole gene aspect, not even looking at the cost of the hospital stay, potential ICU. Legislators were like, we have to pass this. Typically, it's hard to pass any type of legislation if the fiscal note is astronomical. Right? So when we looked at what the potential fiscal note can, look like, and we didn't say everybody who has the condition. I really tried to be pragmatic and say some people would not be able to tolerate it, given where they are, their age, their fragility, other comorbidities, things of that nature. So I was conservative. And even still, we had an extremely large fiscal note. And then they said, where do you administer CAR-T? I say CAR-T can be administered inpatient or outpatient. some facilities that have been doing it for a while in the Northeast, California, they have transitioned to administering outpatient. If you administer outpatient, it goes through Medicaid pharmacy because then it's considered an outpatient drug. So even if it's outpatient hospital, it goes through Medicaid pharmacy, and then you can do rebates. So therefore, that sort of, decreases that large number. But if it's an inpatient drug, there is no rebate, there is no price negotiation. So then who pays for it? Well, we don't have money to pay for it, but we say we put it in the per diem. That means that the hospital pays for it. So we said, yes, we're going to put it in the per diem because once again, that's that risk pool thing where you say, there's a per diem and from an insurer per member per month. They get paid a certain amount per member per month. And if you have these few patients now that need this, $2 million treatment, suck it up, tough luck. And so the hospitals were like, so everybody's like, oh yeah, we got CAR T, Medicaid, Louisiana Medicaid has CAR T. And so then the hospital reaches out and say, the hospital that's able to provide it reached out and and said, we cannot provide this therapy because, and it's like, well, no, we'll pay you at the end of the year. Just put it on the cost report. Say this is the access that, over the per diem, X number of dollars. So let's just say if it's $5 million, you put that in the year cost report, and the state will, at some point in time in the near future, after the end of the year, reimburse you for that. So, that's a tall order, right? So if I tell anybody, hey, I can give you $5 million 5 years from now for all the work that you've been doing, or I can give you a paycheck every 2 weeks, people are going to say, give me my paycheck every 2 weeks, even though they would like to get the $5 million. So similarly, even though we think that, some hospitals are just like, rolling in the dough, they may not have these extra funds to be able to support this. So unfortunately, they said we can't do it. And so we're at an impasse right now. So what it would require is either for there to be a certain degree of proficiency with the provider in the system, because you've done so many cases with commercial employees and people who are commercially insured, that you say, hey, we're now able to offer these in an outpatient setting akin to Sloan Kettering and the Mass Generals and things of that nature. And then we can put it on the outpatient pharmacy.
Wait, I have to ask you about that, because just so you know, you want to do bite bagging with CAR T.
I'm not saying I'm not.
When you put it on the outpatient pharmacy benefit side, it comes from a pharmacy as a patient-specific prescription that you're now going to ask the hospital to administer it. So yeah, they don't do it like that. It's outpatient, but it's buy and bill.
It would not be at an independent, like just regular. It wouldn't be not even a specialized pharmacy. It would probably be at the hospital pharmacy, but it would be at when I say outpatient, I mean outpatient hospital, not like just at a. Yes.
That's called clear bagging. That's where we walk it over. But it's still, again, if you do this in the Northeast and outpatient, they are still doing medical buy and bill. You're just doing it as an outpatient. So hospital-based outpatient, which you don't get the rebates, but you could get other cost of goods that would decrease.
No. So once again, as I said, there are no two Medicaid programs alike. I think that, I look at some of the other states and I say, that's the utopia. I wish I could say I'm going to build a whole bunch of affordable housing and do all these novel things in order to support Medicaid patients, but we just don't have it in our coffers here. But I'm just saying, like, that is a potential mechanism. But, that may not have to happen. It may be that legislators say, hey, we have to appropriate more funds in order to be able to cover it in the inpatient setting. I'm just saying that is a potential workaround if we were looking to say, okay, how can we cover this if it's not, if we don't change our current legislation saying that it's part of the per diem.
So to that end, what can we do specifically to help advocate for that?
Right. So I think that it's providing visibility. It's going to the table. It's going, and creating a bill, working with a, legislator, creating a bill, then going and advocating and saying why this is important, saying why it's a game changer, how it can, even though there is this, extreme near-term cost, the long-term health of this patient, it can be near curative, what it does for families. If you have one of those synecdoches, right, where you say, I'm making up some example, you have a 34-year-old mom that's safe or dad, and how that stabilized the household and it prevented kids from going to DCSF. It prevented other expenditures for the state. It allowed for that person to move off Medicaid and then return to the workforce and be able to, be a tax-paying citizen. I think it's that type of narrative where you start to finish. It can't just be that we paid this money, this person got this therapy, and they lived 6 months. It has to be something that actually says that this here is going to restore this person, and being able to articulate that in a manner that they get it and they understand that, yes, there is this upfront cost, but the downstream effect, the impact, the total savings. I mean, if there's something that, some predictive, there's like the ICER reports, things like that talk about different treatments and the cost and what is the long-term projection, having that type of thing, but making it very elementary for people who may not have a medical background to understand is important. And you got to have like a legion of people, right? It has to be like one of those where everybody goes in. The whole hospital just walks in and everybody goes to the table and talk about why this is so significant. So it really creates an impression and say that this is something that is necessary. Because we know that there are inherent differences between public insurance versus commercial or private insurance.
Sounds like a good CAGLA project. I do have one other question. I'm sorry. Sorry, I'm hoarding the microphone. Clinical trials. So you touched on how Medicaid will pay for everything but the experimental therapy. Appreciate you saying that, because it's a big misnomer from a lot of people. They think like, clinical trial will pay for everything, but that's not the case. So you said that they would cover for patients to travel. What about out of state?
If it's deemed to be, so of course these things have to undergo prior authorization. I would like to say that certain things are ubiquitous, but we know that there are differences in plans, right? So plans have a certain degree of autonomy in how they choose to administer something. If it is that, if there's a compelling reason for this person to participate in this trial,
like no other treatment options in the state, no clinical trial options, then Medicaid would consider that. Okay.
Yeah.
That's good to know.
Yeah. And so, and you can always advance it, right? That's when I'm the whiz, you call on me and you're like, oh, which Glenda didn't help me out this time. Can you assist me? And I try to sort of, have that conversation between the care plan CMO and find a happy medium.
Okay.
And so I know that when those treatments came out, they were really expensive. And so I'm just wondering, does Medicare cover those now? And
So Medicaid still covers the Hep C. That was a subscription model. So for the most part, it was supposed to have been a one and done curative treatment. And so there were a number of parameters that we worked on at the time. Once again, these things have to be a priority of said administration. At that time, we had Secretary Gee, and so that was a priority for that secretary. And so, there are things that, ebb and flow, right? So we know, and so I think the fact is that these are not one and done therapies. So a person may need so many units, right? The units is based on the weight of the person. And they may need a series of treatments. And so it's hard to say what that cost is and then have to have that conversation with the drug company. Also, when it was the Hep C subscription model, there was only one entity that we were dealing with. Right? It wasn't dealing with this company here and this company there. So that also makes it significantly more challenging to try to have these negotiations with different companies when it comes to these therapies. And so and there are certain things that we have to do within Medicaid. Like we have to, if something is FDA approved and it's on the, there like certain things they can go on the preferred drug list and non-preferred list. So it becomes a little bit more nuanced. But what made Hep C easier is that it was a one and done, and then there was only one company that we were working with, so we were able to really finesse that and develop that relationship.
And is there any ability to follow that patient and the continued cost of their care or cost savings of their care?
I wish I could say that we could have that. There are some challenges that we have in Louisiana. One of the things is that we do not have a HIE. So the Health Information Exchange, where if a patient cycles in, between Medicaid and outside of Medicaid, also, if they go between plans, we don't have that that type of infrastructure. Our Medicaid repository is pretty limited. We look at mostly claims data. So if the patient hasn't engaged, it's hard for us to really track them and see how they're doing and so forth. So I wish that we did have that type of information. Also, we don't collect all the codes that you would normally collect as well, right? So Z codes are very important. That's another provider burden. We ask them to, collect all these social determinative health codes and see if a person has been incarcerated. Have, those types of things that we think are factors when it comes to transmission, but also in them, having a healthy quality of life. So there are some challenges that we're still trying to overcome from a technological stance. We are working on trying to get some data, but it would be extracted from national data, which is not the same as having actual state-based data. So until we're able to mend some of our tech silos, it's going to be hard to really do that type of effective tracking.
Thank you.
All right. Any other questions for Dr. Hebert-Magee?